Sarah, we just have to let our viewers know about the upcoming World Anemia Awareness Day,
a global anemia-a-thon.
This will be the largest anemia and iron deficiency event in history. I love that all of us joining the Anemia-a-thon will raise our hands for blood health. You know how much I love getting my hands up and unlocking my dance moves.
And we'll be helping to kick off the Anemia-a-thon at the PBM conference.
And along with a very exciting team of global leaders on blood health.
And our hands will be up, possibly with a cup of coffee. Anyone and everyone who cares about blood health will be joining.
So don't miss it. The sign-up form is below. Welcome back to another episode of Patient Blood Management. Hello, Sarah. How are you today?
Hey, MaryAnn. I'm doing really great. You know, a lot of people ask you and I, how do you implement patient blood management within a healthcare system?
True.
So we have decided to kind of shed a little bit of light and discuss that. And we thought, who better than the dynamic duo from Rochester, New York.
The Wonder Twins.
The Wonder Twins. We have invited Christine Cahill and Majed Refaai to tell us how did they do it. So this should be a very interesting conversation.
This is going to be great. Yes, yes. Welcome to you both. Thank you for joining us today.
Yeah.
Oh, this is wonderful. Christine, would you like to start? Would you like to tell us a little bit about yourself? And then I'll ask Dr. Refaai to tell us a little bit about himself.
Sure. I always love talking about myself. So my background is in nursing. I worked primarily in pediatric cardiac intensive care, and I gave countless amounts of red blood cells, platelets, all kind of blood products. And the parents would always ask me, is this blood safe? And I would say, absolutely. It's absolutely safe. Don't worry about it. When I started my job with Dr. Refaai, creating the patient blood management program here at University of Rochester, I felt horrible for all the things I had said. I unintentionally lied to so many people, but that was the training that I received. No one ever told me any different. How would I have known? So one of the goals that I had when starting this patient blood management program was to educate nurses on what the benefits and issues are with transfusion. They need to know what to look for. They need to know when it's appropriate, when it's not appropriate, when to advocate for your patient, when to help educate your patient, and sometimes even to educate the team that you're working with. So that was really a huge eye-opening experience for me starting this blood management program and all the education that I received from Dr. Refaai and the blood bank here at the University of Rochester.
Dr. Refaai, how about you? Tell us a little bit about yourself.
I graduated medical school from Aleppo in Syria. I moved to USA here. I started with my research fellowship at Mass General Hospital, Harvard University, with Dr. Michael Lobosada, who was a coagulation person, basically per se. And that's what made me really like coagulation, which was my biggest enemy when I was in medical school. Being with Michael Lobosada for a while, I really liked coagulation. And from there, I decided to go into transfusion medicine field. And that's when I moved to Washington in St. Louis, Washington University in St. Louis, Missouri. I finished my clinical pathology specialty residency and then moved to UT Southwest with another big name in coagulation, Dr. Ravi Sirode, and then finished my fellowship of transfusion medicine there and joined University of Rochester in New York back in 2007. So that's kind of like a brief story about how I got to become a transfusion medicine doctor. And my first things was the coagulation door to it.
What was the magic that brought the two of you together and helped to start this patient blood management program?
Well, since I joined the University of Rochester back in 2007, probably I would say 3 years into that, around 2010 or so, we became more interested in saving some of the blood products utilization because basically it was out of control, to be honest with you. I mean, like you get the request for unit of FFP or a unit of platelet just to fix a lab results, So that's really start annoying us and start to get more often. At that time, Dr. Blomberg reached out, Dr. Neil Blomberg, who's the medical director of the transfusion medicine at University of Rochester. He reached out to the hospital administration and requested that we should do something about it. During that time, there were not much of interest, not much of help. But then what triggered that is our budget increased like almost 20%, to be honest with you, just because of this inappropriate and extra transfusion that we see it, but we can't do anything about it because there's no help, no support. So then we found that the hospital leadership approached us actually and tell us, okay, now you have to do something about it. That's when Dr. Blomberg said, okay, we can initiate a patient's blood management program it's been increasingly spreading all over USA hospitals and universities, and we can definitely do something about it. So we came up with a plan. That was the first step, is you have to have a plan of how you're going to start this program and who are the players and what exactly the aim of this program, what's the cost and how much saving are you anticipating. So we sat down and we thought about all of these point by point and discussed it with the hospital leaders, and definitely they supported us and they encouraged us to go ahead and start. We first started our patient's blood management program. It was initiated in 2014, if I remember correct.
Yep.
Yep. And that's when I start looking for a coordinator, because definitely we need some help. I accepted to be the patient's blood management medical director and to lead this from the blood bank part of it. But at the same time, you by yourself, you cannot do everything. Even with a coordinator, a program coordinator, still, you need some help from the heavy users and from other different departments, because you cannot control everything. I mean, you are not there 24/7 and not there for every single order. So it needed a lot of work. So yeah, I would say second step is to look for the coordinator, which we did. And I interviewed several people until I decided to go with Christine, just because my first question to her, what do you know about the blood? She told me it's red. So I found this amazing, like, oh, great, you know the color. So that's
it's more than some.
That's how I started. Our major issue now is to develop some transfusion guidelines. And for these, you need definitely to meet with the heads of each department or each service in your hospital and try to come up with something that everyone will agree on. When do I need to order this? When can I transfuse this? When, whatever. So for that, we really need some people who could help you with the initiation of such guidelines.
Sure.
You need some people who do believe the same what you believe in, because you cannot convince someone that I'm not gonna give you platelet because of just like 2,000 or 3,000 below the cutoff you are looking for. So you need some help from there. We were lucky that we found some really blood management champions in our hospital. I'm not sure if that's available in every hospital, but to be honest with you, I could say, and Christine could agree with me, that we got lucky.
Sometimes you have to make them.
Yeah. Exactly.
They may not know they're a champion until you talk to them.
Yes.
Christine,
yes.
I find it very interesting that you are a registered nurse and yet you work in the lab. That's very cool to me. I know you pretty well, and I would say that you are quite the expert in transfusion in comparison to many nurses and even probably a lot of doctors. And that must have taken a lot of work and a lot of time to develop that. What do you think is the most important piece about you being a nurse and this program being successful? Why does that work?
I think In our setup, with me being in the lab, it actually put me at an advantage because it allowed me to become kind of an ambassador between the lab and the clinical world. And the clinical world and the lab don't speak the same language, number one. They speak very different languages and they don't have the same perspective. And while both pieces are very important to patient care, they don't always know how to communicate with each other. So initially, when I first started, I really did think they were speaking a different language. I would go into these blood bank meetings and I'd be like, I don't know what they're talking. I had a pad and I would write things down and then I would go back and ask Dr. Refaai, what does this mean? Like, I need a translation here.
I get it. I get it. Like,
So
I know
that was the beginning, and that's where I started. And then once I felt a little bit more comfortable, like in that realm, I was able to sort of give them the perspective of like what a clinician would say. I was like, if you say that to a clinician, this is what they're going to think, or they're going to look at you like you have three heads because they're not going to know what you're talking about. So this is how you need to say it. So it was really helpful once I sort of got my feet wet a little bit in the lab, where obviously I'm not like as expert as Dr. Refaai is. I didn't go to school for this, but I'm kind of able to bring the two worlds together. I don't always have to understand, and neither does the clinicians. They don't always have to understand everything that's happening in the blood bank, but they need to know that it's there. They need to know that resource is available and how to contact them and what they can help you with. Half the time, they just want their lab results.
Yeah.
And they don't even understand the lab results. So we really worked on becoming more of a consult service. And I think that's been invaluable to our clinicians at the University of Rochester.
And just building that trust, I think, so that even if I don't know your perspective because I haven't been trained in it, I trust what you're telling me. And we're going to work as a team and figure this out, I think is so important. What made you interested in the role when you saw it posted? Were you just like looking for a job change and then like anything would do? Or was it, no, this really interests me?
Well, I mean, it's initially, I'm not going to lie, I was a little bit like, okay, I'm looking for a job. I went back to school. I got my master's in business. The University of Rochester has a great program that allows their nurses to go to school. And for some reason, I just wasn't really attracted to the nurse practitioner role. I wanted something different. I still wanted to be in something that's relevant clinically. I didn't want to just do like quality or against quality people. They're wonderful as well. But I wanted to do something that would sort of make a difference in how people are cared for. So I applied for all these bunch of different jobs, and most of them were quality kind of jobs. And then this one sort of came up, and I was like, patient blood management, what is it? I Googled it. I didn't even know what it was. It didn't exist in our hospital. I started looking at some of Dr. Refaai's publications, Dr. Blumberg's publications, and I was like, these guys are renegades. These guys are like bad, you know what's.
Right.
I'm like, I need to be part of this. This is exciting.
Yeah.
And like, why doesn't anybody tell us this stuff? Why? I was almost angry. Why did no one ever tell me any of this? So when I went to interview, I really wanted the job because I knew I could do it. It also appealed to me because it was something that didn't exist. So I could have a part in building it and doing it the way I wanted to do it, as opposed to like someone training me how to do something and then following up like a protocol. So that was really something that attracted me to the position as well.
Yeah, it has a lot to do with leading change and doing it in a way that doesn't seem like insanity. It seems like it makes perfect sense. So good for you.
I think you make a good point, Christine, in that hospital organizations are looking to implement PBM programs. There's not a lot of us that are experts in that, but you don't need to be an expert. You need the dynamic between the nurse coordinator and the lead director, the medical director. You need that to be a tight dynamic, which I think I credit your success at Rochester is the dynamic between you two. You work so well together.
Yeah.
And you need the drive. Everything else can kind of be taught to you in time. You can be successful if you have those two things.
Exactly.
So, Dr. Refaai, I have a question for you. Rochester structured this under the blood bank department, correct?
Yes.
You're under the blood bank. Is that the appropriate place to put a patient blood management program? Because, sometimes people see patient blood management. No, we're talking about patient's blood. We're not talking about donor blood. Do you feel like you placed it in the correct structurally within your organization in the right spot?
I think so. I mean, to be honest with you, we never thought about this to be in a different department or different unit. I think the blood bank is the most appropriate place for this as a patient's blood management. I know some programs across USA been added either to anesthesia mostly, or some of them hematology actually also. But again, it's not like when you deal with your own blood products. I mean, the blood bank would be the best place to start with because you are talking the same language. You know, it's not, I mean, yes, anesthesia may have different view on when to transfuse the patients versus when not to transfuse, hematology as well, with all due respect to their decisions. But definitely the blood bank deals with ordering products, storing products, and modifications of these products, the releasing the products, complications, all of these transfusion reactions. I mean, there's a lot of things behind the scene that the blood bankers has to be involved in, from the lab tech until the supervisor, until the medical director. I mean, there's all of these levels involving in all of these decisions. So having this patient's blood management as part of their daily work, I mean, it's their bread, you know, it's that's who are making all of these guidelines, that these are the people who are dealing with all of these orders every day, every night. So I think it's the most appropriate piece is to be in the blood bank.
You're also positioned to interface with the entire hospital. Whereas anesthesia interfaces primarily with surgery.
Surgery.
We interface with the cancer center,
Yes.
with trauma, with the ED, with
Everyone.
the medical world, dealing with different other departments that anesthesia maybe doesn't have as much purview over.
Yes, exactly.
Christine, I'd like to ask you, now that you've been a part of it now for nearly 10 years, coordination is a big part of what the nurse can bring to this position in the organization. That was my first title as well, was a coordinator. Do you think that that's the appropriate leadership title or role for nurses now that you've done it for 10 years? Or do they do so much more?
They definitely do so much more. I mean, I think coordination is just like one of those like catch-all phrases that nobody really knows what you do. When I tell them what I do, they don't understand. And then when I actually go into detail about all the different areas that I work in, they're like, well, what are you? I'm just basically a jack of all trades at the hospital. So, I mean, I serve as an educator. I serve as a resource. I serve as scheduler sometimes. I schedule a lot of we have residents, anesthesia residents, we have cancer center residents and fellows that come through.
Sure.
So I do all their scheduling so that they can have an opportunity to come through the blood bank and talk to all the physicians with our patients who decline to accept blood products. And I talk to them about what we can do to support them. We go over different aspects of blood fractions and things like that. If they have questions. I also talk to patients and patient families who have concerns about blood, because there's a lot of people that have concerns for different reasons. Some of them vaccines, some of them safety, you know, lots of different things. I also work with patients and families and educating them and being an advocate to them and what they want. Sometimes they don't know how to talk to their physician or ask questions, or they're afraid to ask. So I can kind of help with that as well. I mean, I do so many different, I sit on so many different committees. I do simulations. That's been really a lot of fun. I have jumped into the simulation world, and now they add in a lot of like massive transfusion simulations. And you would be surprised how many people don't know how to get blood from the blood bank, or don't know where the blood bank is, or don't know like what the best way to get it, or you know how to phrase it, or what they're going to get. So I get a lot of questions, and I'm able to do a lot of education in that realm too. And it's a nice way to do it because it's more real life. It's not like sitting at a podium and giving a lecture. Like that's so boring. It's way more fun to really be like in the mix of things.
Yeah. I know you've probably wrote a few policies as well.
Yes, you.
Yes. I just want to add one more thing to Christine's also. So in addition to the policies and the protocols we wrote, she also involved in multiple publications about this in general. So I just like to give her the credit that it did lead to several publications in patients' blood management and different policies. Go back to you, Christine.
Yeah, she's an excellent writer.
Yeah.
Who are your big champions? You don't have to say their names if you don't want, but the departments, like who is important to have on board for successful implementation?
You want to go ahead, Christine?
Sure. So cardiothoracic surgery was our first one.
Yes.
They carry a lot of weight in the hospital. People respect cardiac surgeons, and they do use a lot of blood. So we have one that is like, I would think he was a Jehovah's Witness if I didn't know better, because he hates blood. He does not want it to be anywhere near blood. He doesn't want his patients to get blood. And he has been so instrumental, and he's very well respected in the hospital. So
I don't think there's a problem with mentioning his name, Christine.
Peter Knight is his name.
Yes,
Yeah.
Dr. Peter Knight.
Yeah, he's been great. He's helped us a lot. And he actually helped champion the anemia clinic. So we started a pilot program just with cardiothoracic surgery because he was so interested in it, and he really opened the door and really championed that. So when we started our anemia clinic, we just to make it easy and just kind of work the kinks out, we really primarily focused on his patients, cardiothoracic patients, cabbages and bypass, things like that. And we were really able to get the system down so that it was a very well-oiled machine. We were able to figure out where we were going to get our resources because basically the hospital was like, yeah, sure, start an anemia clinic. We're not going to give you any money. So you have to use the resources you have.
Yeah.
So we were able to use resources from the cancer center, use resources from anesthesia, resources from the blood bank. And we just kind of cobbled together this program. And now it's its own very well-run program, multiple nurse practitioners, multiple anesthesia physicians. They have their own infusion chairs. They have their own space that's kind of within an ambulatory procedure center that's off-site. And they see patients from every single discipline. They have, they have waiting lists for patients. Sometimes they can't even get the patients in fast enough.
Sure.
So it's really caught on. And there's been so much research lately and publications coming out on anemia that everybody's interested. Now, like OB is interested, and I think that's fantastic.
Yeah.
And that's an area that we're really trying to explore as well.
OB was one of our, when we look at our greatest accomplishments and our anemia clinic, the OB, our OB docs really picked that up. And then they just set a goal, like no mother shows up for delivery with anemia. And they've used that anemia clinic so wonderfully. I want to back up a little bit to the cardiothoracic surgeon, because I think that's really important. We also had a cardiothoracic champion that was great. There is this, with cardiac, there is this, well, you can't wait too long. This is the people's hearts and they're very afraid and they want to get into surgery. So it's interesting that you started your anemia clinic in the cardiothoracic. Like, how did you handle that where there may not be enough time?
Well, mostly our anemia clinic started on more elective procedures than like urgent procedures. With a connection with also one of our other champion is Dr. Michael Eden from anesthesia. He's also a big champion of our program. Together, anesthesia, cardiovascular, hematology, Dr. Frank Aqua, and the blood bank. All of us, we generated kind of like a committee and start meeting over, I would say, probably took us about 6 months to initiate protocols, policies. Some fellows at that time, which are now leaders in this program, they were with us. Dr. Glove, for example, I think she was fellow at that time. So we started this program. We start writing these policies and protocols, how to identify the patients, where to send them, how to follow up with them, what to treat, PO versus IV iron. Do they need the APO? Do they need to be seen at the hematology clinic? Do we have to send them to the apheresis unit to do the IV infusion? So all of these has to be arranged. It took us literally close to 6 months to just establish some policies, and then maybe another 6 months just to do it really the right way. We created algorithms. All of this were published already. We created algorithms of where the patients will come, what the options of where these patients will go. And believe it or not, we were able to even diagnose some patients that they were coming for, Christine will know better, that they were coming for elective cardiac surgery. They ended up having leukemia. They ended up having some other issues, and now we are shifting their significant medical conditions or medical problems. So we identify some patients who having a kidney failure, and like it was at the beginning, and that was the reason for their anemia, and nobody paying attention to it. So now they have to fix that issue before they fix their cardiac issue. So it did help a lot, and we were able to even right now a lot of other subspecialties start interested in anemia clinic, as you mentioned, Sarah, OBGYN, they came to us. They said, we need to add our patients. So we have vascular surgery, although vascular surgery there's not a lot of elective, like mostly urgent, but they're trying their best when they have elective or when they have time to send their patients to our anemia clinic. So yeah, I mean, there's a lot of issues that need to be dealt with in advance to initiate a successful anemia clinic.
There's a couple of things that he kind of didn't touch on, I think, to kind of help with speeding the process along. One of the things we developed was a reflexive anemia panel, so that the physician could just order something quickly. The patient would go get their blood work done, and then only the test that they needed would be run. So they didn't have to come back, oh, we didn't get this test, and come back. So that would waste time. That kind of helped with diagnosis. We also implemented having point of care hemoglobin testing in some of the clinics, so that if the patient came in, they didn't have a hemoglobin at their initial clinic visit when they decided to have surgery, they could say, okay, we're just going to do a quick point of care hemoglobin and find out, instead of sending the patient. And God knows, the patient takes a week to get their labs drawn, and then you waste a week. Now we know, okay, yes, you're anemic. We need to get this process started. And we also had some fast track beds, so that if the patient was coming from out of town, we get people from hours away coming to our hospital. We had a couple. I mean, we didn't have very many opportunities to use this, but every once in a while we would be able to, all the stars would align, and we would be able to use the fast track program and just send the patient right from their initial clinic visit. You're having surgery, you need to go right and have your IV, right, your first dose of IV right now.
Yep.
And we also did find that even patients that only were able to get one dose of IV iron prior to surgery still gleaned some benefits from it. So, to say that there's no time, there may not be time to do everything perfectly. And honestly, where in medicine do we do anything perfectly and well thought out? Usually we're flying by the seat of our pants anyway. So if you could just get one dose in, still can benefit the patient.
Yes.
We found the same with our cardiothoracic surgeon, who was a champion. Is he was like, you can come in and you can train my staff to look for anything, right? So we really started with training the staff to look, did this referred patient have a history of anemia? If so, when they come to speak to Dr. Morant, we're going to get these labs and see where they're at. And all those things kind of speed up the process. And also just knowing that no time is wasted, like you said. Even if they get IV iron or an EPO a few days before, there's benefit. They are now increasing their blood production, and you can follow them after the surgery with your PBM modalities. And so definitely, whatever the case is, you can always implement patient blood management. There's no wasted time.
Also, we noticed something, Christine, that's some of these patients, we fix their anemia and they come to the surgery, they having their surgery, and then they get lost. We don't follow up on them. I mean, we found this is kind of like a malfunction and basically in our policy. So we created a policy to follow up with these patients, and we start sending letters to their primary care physician to follow up on their anemia, because it's very hard for us or for our cardiovascular doctors to follow up. So that has to be on the level of the primary care physicians. So at that time, our nurses from the anesthesia and from the anemia clinic, they will write a letter to follow up with the primary care physician. We follow up on some of these patients, and we found that we fixed their anemia even after the surgery. It's not only during the surgery. So that will be very good, because a lot of these patients, they could be frequent flyers, and they will come back again later.
Right.
So we need to fix the issue right away before we just fix it momentarily just for the surgery.
Right. And they also do some dietary teaching prior to surgery, which I think is helpful, because I think we all assume that everyone knows, just eat red meat. But that's not necessarily always. There's other things that you can get iron from, other ways to increase your iron.
How about your greatest challenges? What's been, the thing that you just think, this is our greatest challenge. We're still working on it. Still not as we would like to see it.
So the biggest thing is just getting meaningful data. I've really, made it one of my big goals the last several years to create some dashboards, so that I could, not just to point people out who the bad people are or whatever, but just to kind of help pinpoint where the issues are, help physicians see. Everyone always, it's just like when you're dieting, you think you ate less calories than you did. everyone thinks they're using less blood than they do. And then when you show them exactly how much they're using, they're like, oh, wow, I didn't know it. So it's really important to have these kind of like report cards or ways to glean this data in a meaningful way to show your physicians and your consumers what they're doing. And so that's always been really difficult. I did a lot of paper and pencil work in the beginning. We had our orders come through and we call them the pink sheets. And I went through each one every single day and tallied things. And it was like, okay, is it 1930? What's happening here?
Right.
So I spent a lot of time with IT, and we had a few different iterations. So I said blood bank and clinical world speak different languages. IT speaks a language that's not even, I believe it's hieroglyphics. I'm not sure what language it is, but sometimes, we'd go through different iterations and I'd be like, no, that's not what I asked for. Yes, that is what you asked for. No, it's close, but it's not exactly. So that was a little bit difficult. And I still, to this day, haven't gotten exactly what I need. It's better. I have something and I'm happy and I'm appreciative for that. And I know a lot of people put a lot of work into that. And I really appreciate it. This is not to disparage the work of our IT professionals, because I don't know how to do it. So I can't tell them how to do their job. But I know I've spoken to other coordinators in other hospitals and everybody says the same thing. Like it's just really hard to mine data, and it's hard to really interpret what that data means when you do get a giant data set. Like, now what do I do with it?
Yeah.
How about for you, Dr. Refaai? What's been your greatest challenge, do you think?
I mean, the greatest challenge, to be honest with you, is, part of the patient's blood management, in order for you to keep and maintain the patient's blood management successfully running, is education, as Christine just mentioned. And I found the biggest challenge is you educate this part of the fellows or residents, and then they move on, or they hire a new attending, or they hire a new fellow, and the entire department just flip over 180 degree. I mean, we spent tons of you guys educating you. Christine met even with nurses, and then they get back to us and they start the orders to be like out of order. It's something weird is going on.
Every July. Don't have surgery.
Exactly.
July, August, or September. Don't do it.
Exactly. So Christine will get back again to them, to the nurse leadership over there of that department. What's going on, guys? I mean, why you keep ordering this? Why we are seeing now ordering back again in duplicates? Like sometimes they order 2 platelets. I mean, what's going on? What's happening? Why nobody is following the transfusion guidelines we agreed with your department on it? So basically, they just hired a new doctor. The other doctor left. The other surgeon left. So these are the significant challenge I found, because you have to be continuously doing this. You have to always keep maintaining kind of like patient blood management maintenance period. So you have, and as Christine mentioned, between July and September, our heavy work is during that time, just to educate the newcomers that's, hey, we do have patient blood management. We do have a specific guidelines. Whatever you used to do in your old hospital or old medical center or during your fellow or transfusion, now it's different, So so all of these different practices coming from all over the country, I found it really very challenging to keep touch base on it. And not only this, I mean, sometimes even if the entire unit follow our guidelines, sometimes just one doctor, if they hire just one doctor, it will change the entire unit. Other doctors start following him, and the people who used to follow our guidelines, now they are following his guidelines, or her guidelines. So it really was a significant challenge, and still challenge. And I don't think it's going to go away. I'm very sure every July you're going to have the same issues again, or every time they hire a new
I think this goes back
faculty.
to, we really need to advocate to have some of this taught in medical school and in nursing school.
Yes.
And focusing on patient blood health, just like we focus on cardiac health and cholesterol and all these other things. Everyone knows about these, markers of good or bad health, but we don't ever talk about this. And I think as a person in this field and like as a member of SABM, I think it's something that we really need to start lobbying for.
And so many people have anemia. It's why aren't we addressing this? Do you think that enhancements in the EMR help at all with ongoing gap in education?
You want to go ahead, Christine?
Sure. I do think it's helpful. I think people want to do the right thing. They don't always know. And when they're putting an order in, if something pops up and they know,
Yes.
oh, this, there's a flag here. Oh, I did something wrong. Let me think about this a little bit more. So we do have some flags when an order is made outside of our stated transfusion guidelines, and then we don't have a hard stop.
Yep.
I'm not sure if other systems are like this, but Epic does not allow for hard stops for anything. It's considered a safety feature, but they do have an opportunity to type in something if there's something going on that's not showing up in the medical record or whatever. At least it's a level of communication. But just something popping up that, oh, maybe this is wrong, it causes the person to pause and at least think about what they're doing. And we've had orders come through that they were on the wrong patients. And then we called them and we're like, hey, what are you doing? Oh, I meant to order that on Mrs. Jones, not Mrs. Smith. And it's like, oh, okay, well, thank God we caught that one. So it's really important to have these things, just like in the OR, they pause, they make sure that everybody knows what's going on. They're doing surgery on the right limb or whatever they're doing. They need to have a pause when you're transfusing to make sure that this is appropriate. This is what you want. We've also put a system into place where they can't order more than one at a time. We've feed this into them. You can only have one product at a time, unless it's a massive transfusion situation, and then they get balanced resuscitation. But they can't have 2 red cells. They can't have 2 platelets. They can have one, and they reassess the patient. Sometimes not even one. They order one, and then we talk them out of that one sometimes too. Even. Yeah. But we definitely have made some progress in the double unit orders.
So transfusion's not an option. They've declined. How do you help or serve that population?
Now, this became part of our anemia clinic. I mean, to be honest with you, wasn't initially the goal of anemia clinic, but then we start communicating across the hospital, across all the different departments and different units that we have kind of like, it was part of Jehovah's Witnesses counseling for these patients, and we met with their leaders. And we understood from them that our hospital is not, they call it not a Jehovah's Witness friendly hospital because they don't have the appropriate guarantee that they're not going to get transfused. Even if their surgery does not need transfusion, or even if their procedure does not need transfusion, they still avoid coming to our hospital just because of we may get transfused. So it took us a while to convince this group of patients that we are switching, we are initiating a patient's blood management, we're going to be taking care of transfusions for this particular part of the patient's population. And we start seeing increased numbers. I mean, right now it's part of the anemia clinic that if any doctor, regardless, minor procedure or major procedure, if they do have a Jehovah's Witness patient, or a patient that do not believe in transfusion, regardless, they will be referred to the anemia clinic. And the anemia clinic will email us, me or Christine, mostly Christine. When I'm saying me, it's Christine. Mm-hmm. So they will email us and sending us the patient's information that's X, Y, and Z coming for this type of procedure. This is his doctor. This is blah, blah, blah. So Christine will communicate them, try to set up a time to meet with us and to answer any questions they have. Sometimes I would say maybe at the beginning, 100% they will request us, me and Christine, to be there. Recently, it's about, I would say, 60% of the times Christine can take care of it on her own. Not everyone I meet with to discuss. When we meet with them, we tell them about the other options of the patient's blood products. We reach out to the surgery team or to the doctors, whoever doing the procedure, to tell them about what the patients will take and will not take. We created a list of blood products that they can take or not take. Because again, a lot of patients, they may take, for example, they may avoid red blood cells, but they're okay with cryo or factor VIII concentrate or Kcentra or Nova 7, whatever. Mm-hmm. So we created a list of that with the help of the Jehovah's Witness committee or society leaders, and they review actually this list as we created it, and they loved it, and they start spreading this across all of the Jehovah's Witness population, and these patients start coming back to our hospital. Now we're gaining back almost 2,500 patients that they used to avoid our hospital just because of this patient transfusion thing. Then they will reach out to them, and then, as I said, we'll go through the list and just indicate what to take, what not to take. We'll put a note in the e-record, and that note is for every doctor or every nurse or every person involving in their care during their hospitalization. So they really liked it very much, and now we start getting back these patients again.
Yeah, and even on top of that too, we started kind of doing like a little assessment about are these patients on any herbal supplements, because sometimes that gets missed, that there's things that put them at risk for bleeding. So I talked about people that were on some things that have effects on platelets, and I emailed the team back and I was like, hey, this person is on, I don't remember exactly what it was, such and such herb. You might want to have them stop this like a couple weeks before their surgery or whatever. And so that's been really helpful. And then also talking to parents, like we have a huge children's hospital here, and especially lately, the families have been concerned about their kids getting blood products, kind of like a resurgence, not as bad as the AIDS era, but people are having concerns about the blood supply. And so I speak to a lot of parents, and I tell them, like, I'm a mom, I was a pediatric nurse, and these are the things that we can do to help your child to avoid a transfusion, because really everybody wants to avoid a transfusion, whether you will accept one or not in a surgery or emergency. Everybody wants to avoid it. So like my goal really is to kind of empower them to do whatever they can do to avoid that transfusion, and then make sure that the team is doing everything that they can do to avoid that transfusion in the first place.
Very good.
It's amazing, like you've come full circle there. So cool. It sounds like you've had a lot of successes overall. What do you think is your greatest success for the program? Like looking back from then and now, either one of you, what do you think was the greatest thing to come from this patient blood management program?
I mean, the biggest success, I would say, is a lot of physicians, surgeons per se, they start like on multiple levels. So they start sending us their resident and fellow to spend some time with them for education. That's one. Second, we start getting a lot of consultations. So in the past, when somebody just see an abnormal tick, for example, we have a tick for viscoelastic. When they see an abnormal tick, they will just start ordering blood products on their own. Now we see some calls for consultations. Oh, my patient is this and this, but he is not bleeding, or he is going for procedures. What should I do? So a lot of these, we start seeing them. A lot of different doctors start asking for their patients to be part of the anemia clinic. So they start referring them to anemia clinic. We see that's a lot of not only on the level of the doctors, also nurses. They start asking Christine to come spend some time with them. We need to do simulation of this and this. They contact Christine. Why? What should I do for my patients? What should we do for this one? I do have some people contacted either me or Christine saying that there is a case of a possible case coming. We need to know in advance what to do. We need to know in advance what to transfuse or what to do. What numbers should we worry about? Sometimes they reach out to us and they said, okay, we have a specific part of these patients that they come, and we need to create a specific policy for them. So we also develop special policies for these specific patients population. So these, I mean, all of these, I would say, kind of like success. Definitely, it was a challenge at the beginning, but right now they are asking for it, and they are asking for our help with this.
Christine, what do you think?
Yeah, just to kind of springboard off that, like the relationships that we've been able to make with the entire hospital. And I think even from my own perspective, I think the lab kind of gets they kind of get forgotten. And really these laboratory physicians and techs are really unsung heroes of the hospital. They do a lot. They touch almost every patient in some form or another. And so I think our blood management program has really brought that to light. When I first started, I didn't even realize that there was such thing as a transfusion medicine physician. I thought it was just like a repository where you call and, deliver my blood and it comes. I didn't know all that went into this. And
She
it's
thought
very, very important.
She thought we have an ATM at our blood bank.
Well, There are people in this hospital that would like that, I know. But so I think that's really been something in our hospital that it was an untapped resource that we've just been able to really showcase. And we've won several awards. Our blood banks won a couple different awards, quality awards. And it's just been really great to see that these people who work so hard are now finally getting like some recognition. So
Yeah.
for me, that was a big success that I could kind of at least be a part of that, help in that bridging that gap.
Yeah.
Yes.
Filling
Yes.
that unmet need of education that it's just so lacking in medical education today. Like, I feel like everyone can write for blood transfusion, but it's not their specialty, and they really don't have a lot of education as to when it's appropriate. So
Right.
having a patient blood management program and team on board is just priceless. It really is.
Yes, and one more things to add. I mean, I just want to say that successful patient blood management is not only by the director or the coordinator. It's basically a team effort from the lab tech, as I said, to lab supervisors, to medical directors. There's a lot of issue also with our residents and fellow. I mean, they are a huge part of our negotiation with any order in the entire hospital. So they are, all of these play a significant roles and a successful program.
Very well stated. So I'll want to take away from each of you, but what would you like to leave our audience with when we think about patient blood management? And we have an audience that some are clinically trained, some are patients that are looking at where to get care. What do you think is important for them to think about when it comes to patient blood management?
I would like to say, I mean, for patients, I just want you to understand that blood or blood products are not 100% safe. Okay, just keep this in mind. There's a lot of ways that your anemia could be managed in advance before you get to the point where you have an elective procedure. That's mainly transfusion. Try to discuss the alternative options with your doctors or surgeons before the procedure as possible to avoid transfusion. Transfusion, just think about it this way, is something was in somebody's else body, taking all of the secretions from that body, all of the proteins of that body, whatever the liver is producing, whatever the kidney is producing of that body, and take it, put it in a bag, and then transfuse it to you. So you don't even put a lotion on your hand before you even read the description or read whatever on that lotion is. How are you going to put something inside your vessels and inside your heart and inside your organs without even knowing where it came from? So just keep this in mind. I mean, definitely a blood transfusion is a lifesaver. I'm not saying it's not a lifesaver if somebody is bleeding heavily because of trauma or accident or whatever. Yes, absolutely. But it's not needed to fix hemoglobin from 8 to 9 or 7 to 8 or 9 to 10. Absolutely not. It's not to fix a lab results. So just keep this in mind. That's my message to patients, population. To resident doctors, fellows, definitely think about patient safety and keep in mind that blood products are not 100% safe, regardless. We test for specific bugs, we test for specific bacterial infection, we test for specific viruses, but we don't test for everything. And like you can go back in the history, we were not testing for Zika before. We were not testing for multiple. I mean, it's there. In the 1984, we're not even testing for HIV. So there's a lot of things that we don't know what's going to happen. We don't know what's going to evolve in the future. So just keep this in mind. Would I transfuse this patient, or would I transfuse my sister or my brother if needed? So just think about this. It's not just to fix the lab results.
Christine.
For me, I mean, really, I think the biggest goal of patient blood management is to educate the physicians, educate the nurses, educate the patients. People need to feel they're being supported. People need to feel that we're advocates of them. They trust us. So you need to educate yourself. This is something. Transfusion is one of the most common procedures in U.S. hospitals, and probably about 50% of those are unnecessary. Even just with a little planning sometimes, like, we tend to put out fires, but we really all, I think, if you really want to do the best you can for the patients, we need to take a step back and look at preventative medicine, look at health and wellness, health and well-being. We as providers need to do this, but we as people and for ourselves as well, and focus on your blood health.
There you go. Yeah.
And Christine, when a patient comes to you now and says, I don't know if I want this transfusion, is it safe? How do you answer now?
So I'll say, nothing we do is 100% safe. There's lots of things that we can do ahead of time to try to prevent this. We may get to a point where this is something that you may need. It may be a life and death decision, and something that we can talk about ahead of time. But let's try to do as much as we can to avoid it. And knowing that we're doing the best that we can to make sure that everything we do is as safe as possible should give you confidence that, we're really looking out for you. And if it gets to a point where you need transfusion, we'll give you the smallest dose possible.
Love that.
Thank you guys so much.
Yeah, thank you. It's been a pleasure. It's been an eye-opener. Thank you so much for your time. I know you guys are so busy. We really appreciate you being here.
Thank you very much for having us. I mean, this is a great program.